So our speaker is Keith Clements from the National Children's Bureau.
Hi there. So I'm going to be taking you through an example of how we have used published data on health inequalities to produce impact with policymakers. So I'll be talking a bit about our findings, but more about the how we've done it. And it's a case study from a report that I wrote about 3 years ago, which focused on health inequalities amongst young children, those aged under 5. Firstly, a bit about the National Children's Bureau. We were established about 50 years ago as a charity by local authorities across England to try and bridge some of the gaps between research, policy and practice in the children's sector. What this means in practice is that we support those that are working directly with children to kind of do a better job rather than delivering services ourselves. We do have a strong participation strand, however, and I'm pleased to say that we've got 3 of our young research advisors here today with some colleagues from NCB who are delivering a session on participatory approaches to research and policy in the Fred Miller room at 1 p.m, so do join them later on. So thinking about the context and aims in which we did this work. At the time that we were producing the report, local authorities were taking over responsibility for young children's public health services, in particular health visiting services. We at NCB thought this was, in some respects, a good idea because it would provide opportunities to join services together with other local authority services, but we were concerned about the context in which it was actually happening, that is, the context of austerity. So we wanted to do 2 things, really. We wanted to encourage local authorities to take this new responsibility seriously, and we also wanted to protect early years public health services through funding and legislation. And in terms of legislation, the key thing here was that health visiting services are a statutory service that local authorities have to provide, but this was under threat a couple of years ago. There was going to be a review on taking that statutory status away, so we wanted to influence that. So talking through kind of the 3 tactics that we used in putting this report together. The first tactic was choosing the right topic. And this is not really as simple as it sounds, particularly when you're trying to get the attention of policymakers. I've talked a bit about the policy background and why we chose this topic, but we also needed to choose the right specific outcomes where we could actually clearly explain why these outcomes matter to young people and why the government needed to take action. We also need to take a constructive approach and actually be able to say something about what good looks like on the ground. And National Children's Bureau was lucky in this respect, in that we could point to our work through with the Lambeth Early Action Partnership, which is one of the 5 Better Start sites that operates locally here with young children. We also need to be clear about whether there's space for the messaging that we've got. So we're going to have quite simplistic messaging in this kind of work. So it's quite easy to clash with other people doing work in similar areas. So for example, if other charities were doing reports in the similar area or other media events coming up. And the last thing is whether we can actually easily access data that allows us to demonstrate the need for action. On that point, in terms of easily accessible published data, we're choosing from quite a limited menu of data. In addition to the outcomes data, which I'll talk about in a second, we used mid-year population estimates, deprivation through the index of multiple deprivation, and we looked at it at a local authority level, so the 152 upper tier local authorities across England. Reason being that those are the ones that have got the public health responsibility, but we tend to look at that level as well because they have a lot of other important responsibilities for children. So the 4 key outcomes that we looked at for this report was, firstly, obesity. And obesity is not only associated with cardiovascular disease and diabetes in later life, but also asthma, emotional and behavioural problems, and sleeping problems in childhood itself. Tooth decay is associated obviously with pain and infection, which can exacerbate and go on to cause gum disease, dental abscesses, which in turn cause difficulties with eating, speaking and sleeping. It's fairly obvious why you wouldn't want a child to be injured, but the data that we used was the hospital episode statistics on whether they'd been admitted for an injury. And also perhaps a more kind of conceptual idea is children's level of development. So we use the early years foundation stage profiles, which gives a broader view on children's healthy development across physical, emotional, cognitive and social development. You'll see here one of the other things that we did is use infographics, and you can see I've introduced the 4 icons here, which you'll see throughout the rest of my presentation. So just pausing briefly on how we did it to look at the first layer of findings. This is the 4 outcomes set out across the 9 regions in England, and I've organised the regions roughly north to south going downwards. And you can see that there is a kind of a slope with the poor outcomes being in the north and slightly better outcomes in the south. And obviously the relationship is slightly is reversed for good level of development, because that was obviously a good outcome we were measuring rather than a bad outcome. We compared the 30 most and least deprived local authority areas for the 4 outcomes, and we found that there was 11% of 4 to 5-year-olds who are obese in the most deprived areas compared to 8% in the least deprived areas, 32% of 5-year-olds with tooth decay in the most deprived areas compared to 18.4% in the least deprived areas, and similarly poor outcomes in the most deprived areas for the other outcomes that we looked at. You'll see that although there's still quite a striking difference between the different areas, you'll probably remember from Raki's presentation that there's kind of clearer evidence of the relationship between deprivation and poor health outcomes in children when you go down further to the neighbourhood level. When you look at the local authority level, all local authorities have deprived and less deprived areas, so it is balanced out a bit. The second tactic was how we kind of presented the statistics by bringing it back to the individual. So when looking at the data, we asked this kind of quite simple question of how many individual children would avoid poor health outcomes if we reduced these health inequalities that we've just been talking about. So, if all local authority areas had the same outcomes as the least deprived 5th, as in the least deprived 30 local authorities in England, there'd be a 16% reduction in cases of obesity, equivalent to nearly 10,000 fewer obese children of that age. There'd be a 26% reduction in the number of 5-year-olds with tooth decay, equivalent to nearly 35,000 fewer children with poor dental health. Also 5,000 fewer cases of early childhood injury each year, and 12,000 more children being better prepared for school. The third tactic that we used in the report was to create a local angle so that people could see how these issues were playing out in their local area. Now I've got yes. So this is a video demonstrating the interactive Google map that we created, and people are able to come on here and click on their local area. They don't even have to know which local authority area they live in. They can click on their hometown and it will bring up the statistics for the 4 outcomes for their area, and importantly including the number of children that are affected by those poor or good outcomes in their local areas, really giving them insight into how it's playing out in their local area. Having this local data compiled also enabled us to give tailored briefings to parliamentarians and other policymakers And we also did a series of regional press releases which enabled us to get some kind of very good engagement from the regional press and interest in terms of immediate impact from the report. Speaking of which, kind of a summary of the take-up and the immediate impact. We had very good kind of coverage in the local and national press, particularly, as I said, in regional press, also social media. We launched the report in Parliament, had kind of good attendance at that. We had a dedicated debate in the House of Lords and presented to the Chief Medical Officer on the findings. And I'm reliably informed that it's still the report Poor Beginnings is still referenced to this day, 3 years later, by senior civil servants. So we've definitely got into people's consciousnesses, which is good. Looking at actually what's happened in policy terms, in terms of what we were trying to influence since, in the debate in the House of Lords that we secured immediately following the launch of the report, the Minister responding for government did give assurances about the role of Public Health England in supporting local authorities in this area. And there's been a number of kind of resources that they've published since. As I mentioned, we couldn't take for granted at the time that we published the report that health visiting services would remain a statutory service. After a review carried out by Public Health England, the regulations that set that out have been continued kind of basically in perpetuity, which is great. So those services are protected, and the number of families that are actually receiving the 5 visits, which is the core bit of the health visiting service, is monitored and published. In terms of the less good things that have happened since we published the report, ideally we wanted to protect the resources that local government has to spend in this area. That was quite a tough ask for us to kind of influence. Unfortunately, the public health grant, as a lot of you will be aware, has been cut by about a fifth, or is being cut by about a fifth between 2015 and 2020. The government's chartered obesity strategy, when it was first published in 2016, unfortunately largely ignored the role of local authorities, although the second chapter, which was published earlier this year, has highlighted a new Trailblazers programme, which is launching soon, I understand. So in terms of the lessons in making impact from published data, I took you through the 3 key aspects of our strategy, which was choosing the right topic, the 4 key outcomes that we looked at, bringing it down to the number of individual children affected, and also creating a local angle. Adding to this, kind of on reflection about what's changed since and where we were successful in influencing, I also think that partnership working is really important. On the protection of the statutory nature of health visiting services, we were very much part of a chorus from the sector that those services need to be reflected. And speaking of partnership working, we were less successful on funding, but the National Children's Bureau has recently convened a coalition of around 140 organisations and counting, calling for government to put children at the heart of spending decisions going forward. We launched this campaign in the run-up to the budget, but our main goal is to influence the upcoming spending review. So if your organisation's interested in that, do get in touch with me. And yeah, thank you.
I'm going to invite our discussant to come up now. Dr. Johnny Downs is a child and adolescent psychiatrist and a postdoctoral researcher at King's College London. So he's just going to give his view on the presentations we've heard, and then we'll open it up to the floor for some questions.
All right, thank you. How long have I got, Kate? 5 minutes? Yeah. So why do we bother looking at health inequalities? Why is it important for us to think about it and advocate for change on it? Well, it basically comes down to injustice, that we all feel that why should the social determinants of ill health be weighted towards certain populations, certain groups, more than others? And I think thinking about child health is that it's an even greater injustice because children don't have the same personal responsibility for changing their environment that can promote better health than adults do. We need to help them do that. They don't have the opportunity to quite get their mums and dads out to go and earn more money so they get the greater wealth within their household. They don't have the same ability to try and change smoking behaviours within their own bedrooms at home in quite the same way. So the weight is on us to really help that, and I think that's why it's great that we started this conference thinking about child health. So Johan Mackenbach gave a kind of gloomy appraisal of the progressive attempts by the Labour government between 1997 and 2010 to really tackle health inequalities. They had a systematic programme of policies that were really designed to improve health discrepancies. He gave a gloomy outlook because he said there is still not enough political will and there's still not enough population thrust to really change the monies available, to really change the way society wants to distribute wealth. The answer then came back to that to say, okay, all right, as health researchers and practitioners, policymakers, what can we do? And I think the 4 talks that you've seen today have actually illustrate quite nicely what we can do, which is demonstrate how we can improve access for children to get the care that they need. So we're not broadening the health inequalities by providing discriminate access. They talk about how do we, this was nicely done with with James's presentation, is that how do we get practitioners to think about the social determinants of ill health and to think about health inequalities, getting them to ask questions about what the household is like, how much money's coming in, what are the behaviours within the household that may cause problems. The third strand is really important, which is building on the evidence base. And this is Raki's presentation and reinforced throughout our talks, was we need to keep tracking health inequalities. We need to keep showing that there is broadening, where the gulfs are broadening. We need to look at vulnerable populations, and they pop up. They're not always circumscribed from the beginning. So we need to think about young carers, for example, having more of a say about what care they're getting. That's a sort of novel, vulnerable group in the sort of in health inequalities parlance. Got 2 minutes left. And the fourth aspect of it is advocacy, and I think this is where James brought that to the fore, is that you really need to get the data out, to collect the right data, and then keep hammering the message home. And I think that's what's really important about showing models of how do we go from your program, James, how do we get that embedded in a local area? How do we then get enough political will, enough advocates, enough champions to then say, all right, let's try that out. We may tailor it because we've got different population needs. Can we tailor it to our population? We need to see the mechanics of how that works. We also then need to see the effects of those programs and how we can tweak them to be used in other communities. So I think the advocacy story is also very important. I'm going to leave a couple of, well, I've got 1 minute left, so I'm going to leave a couple of questions open really. So we've had some really lovely information again about McPin, and again tapping into this accessibility. I love the fact you go out and you ask, you recruit people in that don't answer things very well. I think that's because that's desperately important in mental health. One of the reasons we reject referrals while working as accounts practitioners is we don't get the right information from GPs in which we can make threshold decisions. So if you want a case find, you really actually should be looking at those that don't give you the right information, that can't really articulate themselves very well, because that is the definition of vulnerability, not being able to advocate for your healthcare. So the question is then, how do we then integrate that case finding capacity into our practice? How do we then get routine collections of data to really tap into those vulnerabilities? How do we find those cases and look at how well they're being represented? And then how do we then get the the programs, the novel, innovative programs, how do we then generalize them? And not just about making sure that the effects are the same in different populations, but actually how do you generalize the will and the determination to get something done in one area, and how do you teach other areas, as we had a question looking at, how do we get this into Lewisham? How do we do that? And what are some of the lessons learned that we can gather from other people? And how do we source champions? And I think the lovely idea of getting receptionists, you just need one. You need one sort of bridge builder, one person that really gets it. And that was a lovely display there. So those are the kind of two broad kind of theme questions about how do we integrate practice, and then how do we generalize? So that's my 50 pence worth. Thanks.